Good afternoon or good morning, wherever you are. I am Leah Binder. I am the president and CEO of the Leapfrog Group, and I am privileged to be able to host today's webinar. We will be talking with some leaders in healthcare that I have found extremely inspiring, and I am so excited to be able to share that today with all of you. This all started when I got a phone call from an old friend who's a young person, but an old friend, CLABSI, who was really instrumental as a purchaser, as an employer purchaser of health benefits. She had a storied career, really improving the health of her employees in really innovative ways and driving true change and engagement among healthcare providers throughout her career, working for some very large companies. So I had been really benefited from her as a mentor in many ways in my role at Leapfrog. So Kathy called me and said, I've been working with these really exciting healthcare providers in the state of Michigan, and I think they're true leaders. They really want to be the best of the best. They want to get healthcare into a whole new realm of excellence. And so I was hopeful that you would work with them to identify the health systems in the country that have truly achieved that level of excellence, where we want the vision for excellence, really, the health systems that are guiding us in the nation. Just look at the data and see what we can find in the country among true leaders, and give that information, work with Michigan leaders to see if they can really explore what those achievers have done and see what they can learn from it and bring to the state of Michigan and for the people of Michigan. So we did work with them. Katie Stewart, our director of our survey, worked closely with them. She to try and look at all the data we had. It was a whole new way for Leapfrog really to look at our data and to look at the hospitals that have worked so closely with us over the years and to identify these high performers. So with that, this group in Michigan, these group of leaders did an exceptionally good job, I think, of exploring in depth what was going on at the hospitals that they identify with us and with Katie. And I was very impressed with what they learned, and I learned a lot from them. So I'm so pleased to present them. So hosting this conversation today are two of those leaders from Michigan. First is Dr. Mark Cato. He's program leader for Michigan Health Improvement Alliance and something called THRIVE, which is a great acronym. And I don't typically like acronyms, but this is a good one. It stands for Transforming Health Regionally in a Vibrant Economy. Love that. And he has over a decade of experience in healthcare quality improvement, data analytics, and financial analysis. And he leads the Achieving the Right Medications for Health, another great acronym project, Armed for Health project. The initiative implements a focused, coordinated action plan to increase education on appropriate prescribing, deprescribing, and adverse drug events, and implements policies and care team models which improve these practices. Along with Dr. Cato is Dr. Sasha Savage, who is Chief Health Officer for THRIVE, that great acronym. Dr. Savage's role is focused on the health and well-being aspects of the THRIVE portfolio, including key messages, achieving intended outcomes, and informing the actions and progress during the multi-phased implementation. Currently, Dr. Savage works at Mid-Michigan Medical Center, where he serves as the medical director of the Family Practice Center. He's involved in leadership and ethics at his employer. He provides peer leadership support as a physician dyad and is active in the system redesign, incorporating the quadruple aim with a specific focus on provider wellness, a very important topic. More recent contributions have included pioneering leadership concerning the issue of provider burnout, system wellness reform, and enhancing provider resiliency. So I want to welcome all of you, our attendees. If you have questions during the course of this, please enter them into the Q&A on the bottom of your screen, Q&A, and we will hope to have lots of time for questions toward the end. But first, I'm going to hand it over to Dr. Savage.
Thank you so much, Leah, for the kind introduction. Really excited to be here today. As was mentioned, we really came here today because of that mutual connection that Dr. Bazzi provided with you, and how excited we are about that. Um, Figured we would start today just a little bit. Mark and I put together a slide that kind of describes where we are locally, since I know this is a national and maybe beyond the national borders webinar. So we are in the Great Lakes Bay region of Michigan, which encompasses the counties that you can see there. And in the work that we've been pursuing, we have had four major partners listed here on this slide. Ascension St. Mary's, Covenant Healthcare there in Saginaw, My Michigan Health here in Midland, and McLaren Bay, which is in Bay City. We've had other partners join us on the way also, but these have been the four acute care centers that have really informed the grand majority of our work. So we are so grateful to have them. With that said, our story starts about 5 years ago. Dr. Bazzi and I are friends, and she likewise, Leah, has served kind of as a mentor for me on so many levels. And she asked me to pull together a task force specifically designed at achieving zero harm healthcare. The concept was to improve healthcare while simultaneously matching it to an improved economy. And she asked if I would pull together leaders from the healthcare systems that could help us achieve that very lofty zero harm goal. And zero harm not only in key measures, but actually in totality. So that was a bit of a challenging thing. And on this next slide that you'll see, what happened is as we pulled together our task force, we began to explore and wonder what zero harm healthcare really meant, and what would be the key pillars, if you will, that such work would be built upon. I'm going to go through these relatively quickly, moving from right to left, because I think that it will end us on what really brought us to this wonderful partnership with Leapfrog. So as we had these leaders from the region come all together, we began to ask ourselves, what does zero harm healthcare look at? And we didn't want ground level process redesign, although we knew that would be important. We wanted 100,000 foot strategic, very high level concepts upon which we could then build everything. And so one of the things that emerged out of there was, as we were starting to work with these healthcare systems, so much of the work was centering in the inpatient realm, but we recognized that we needed to likewise simultaneously develop an outpatient ambulatory care platform that could sustain these innovations once people leave the healthcare system. So one of our first major pillars is the reimagination and redesign of a visionary form of primary care. In addition, we recognized that in our communities, as we are building these healthy communities together, that we needed everyone from top to bottom in healthcare to be highly emotionally intelligent and resilient. This came out of the construct. It's a term from a gentleman by the name of Tom Naska, who's the CEO of the American College of Graduate Medical Education. And he talks about meeting the social contract of our day, which is really meeting the need of our communities. Well, the task force identified that temperatures seemed to be going up in society. There were a lot more stressors, a lot more worries and concerns. And so we knew that we wanted healthcare. Part of zero harm was delivering the kind of care that could almost be like that cool, calming water on those higher temperatures that people were experiencing. And thus came the emotional intelligence pillar. We wanted to also optimize the voice of our people, meaning everyone throughout our communities. And so this third pillar of EMR portal optimization really was one that centered on, we wanted to emancipate, open up, free the voice of everyone, so that we knew what the care was that they needed, how they needed it, when they need it, where they need it. And the portal became the mechanism by which we felt that could be accomplished. But really, this particular pillar could even be redesigned and renamed as freeing up and enhancing the voice of every single member of our community. Well, finally, the pillar that led us to Leapfrog it came out of one of our healthcare systems, where the question to this individual, it was their chief medical officer, Dr. Clark Hedrick. The question was, how do you guys stay up on your innovations in zero harm? And he was very transparent. This was around the time COVID was really taking off. And he said, hey, Sasha, that is one of the greatest challenges of our day. Healthcare is a challenge. We have thin margins. Finances can be very tricky at times, and we just don't have extra bodies to do that. What could we do to really tap into best practice? And thus was born this concept of a learning consortium. And Leah, that is exactly when we turned to Kathy and Kathy turned to you, and we began to explore how could such a powerhouse like Leapfrog, that does such incredible good in terms of advancing zero harm practices, inform and help us kick off this concept of a learning consortium. And so we met with Leah and had just a wonderful discussion and began to unlock some of those opportunities. So thus really, we at the Michigan Health Improvement Alliance, of these 4 pillars, we wanted to start with the learning consortium because we felt it would give us the greatest immediate learning, and it would also put us in partnership with Leah, someone like you, and with this organization. So with that, Mark, if I can pivot it over to you to have you carry it for a little bit to describe that journey.
Absolutely. Thanks, Sasha. And thank you for this opportunity today, Leah. As Sasha pointed out, those 4 pillars were all conceptualized by each one of our health system partners. So the Michigan Health Improvement Alliance, we're a convener and a backbone organization. We engage our region and we engage our partners to help them advance this zero harm initiative. We're not coming to them with here's what you need to do, but here's how we can work collectively within that region that you saw on the map. So in essence, our question is, how can we provide the best zero harm care for our patients within that region? And for those of you on the webinar, when you look at a region like that, we share staff, we share providers, we share nurses, we share clinicians. So if we approach this as a health system approach and we all start speaking that common language and have that common vision, it makes it easier for staff, it makes it easier for community members, it makes it easier for everybody to understand. So as we embarked upon this, the question was, how do we measure it? And it was, let's look at collectively our Leapfrog data and our Leapfrog scores, because it has been collected for numerous years, it's standardized, and it's been scrubbed. There's really no discourse or debate about, is this data valid? Is this data good? Because everybody has this set of data that's published twice a year. So that is what we adopted. And so as we move forward with that conversation with Leah, she introduced me to Katie, and we had numerous brainstorming and web sessions about how do we pull this from that massive amount of data and resources that has been put into it over the numerous years. And what we landed upon was the last 10 grading cycles. That is how we measured sustained performance, because everybody knows how hard it is to go CAUTI free, CLABSI free for 6 months. We said, okay, looking at this data, let's look at the last 5 years. So we identified hospitals within each domain that had zero incidences of harm in each category for at least 5 years. So within our health systems, we asked our patient safety task force that brainstormed these 4 pillars, give us your best and brightest regional and safety quality experts. Give us the people that can drive change and have a vision and can lead others. So we formed our team. And then once we formed our team, we partnered with these hospitals all throughout the country. And so I'd like to expressly thank from the Scion Health System, Logan Regional Medical Center out of Logan, West Virginia, Intermountain Riverton out of Utah, and Advent Health North Pinellas out of the Tampa area. We collaborated with them through multiple sessions, and it ended up being multiple because once we got together for 60 minutes, the conversation just overflowed. And our team wanted to learn from these various teams and vice versa. We even had one of the teams we worked with said, we're going to do this on one condition. You allow us to tag along and piggyback off these learnings. So there was really hunger for this type of knowledge and for this journey across the entire nation. So putting this framework around and getting the engagement was really great. And that's why we're glad we're able to share this with you today.
Yeah, thank you, Mark. One of the things that we learned in this journey, I don't know how many of you know of Bill Mollison, but he's a pioneer in my book that attempted to really kind of develop sustainable agricultural practices in an ever more urban world. And he said, though the problems of the world are increasingly complex, the solutions remain embarrassingly simple. Mark and I really went into this journey thinking that we would find process redesign or products that would help us achieve zero harm. What we found was a brilliant and incredibly simple pattern of how to reproducibly go through this. As a matter of fact, we were stunned that as we talked to these organizations who were so gracious in sharing, they didn't know each other. They couldn't possibly have prepped together, and yet their message was consistent and reproducible in every one of their systems. So that's what we want to share with all of you today. That's the really exciting learning. So as we move to this next slide, you're going to see here in front of you the major learnings that that came from that. Mark, are you able to advance that slide? There we are. So the learnings that came. What's that?
I think we should have a drum roll. I should have added that in.
Yeah. So remember that incredibly simple comment by Bill Mollison. That's what we came away with. But what we believe we uncovered with the help of these incredible partners is something that is so almost revolutionary in its simplicity and its applicability. So when we were talking with these folks, almost immediately, the first message from each of these systems was, hey, if you want to really drive to zero harm care, if you want to truly achieve 5, 10 plus years of zero in these reportable domains, your nurses have to drive the protocols of frontline engagement with patients, with safety, with providers. Without that, the nurses are really the best positioned and the most skilled in implementing zero harm initiatives. I then asked the question, so what do you do when, providers maybe have some different ideas? I've been practicing for 25 years. I know that there have been plenty of times when I have my own ideas about how something ought to go. And they said, well, that's a great point. We value the voices of the providers, but we also recognize that providers don't necessarily always understand how the safety protocols were put together, nor all the elements that are involved with them. And so we have chosen to identify provider champions who then serve as a very effective interface between the nursing leadership who owns the safety protocols. And then in that interface, the provider champ is able to bring provider concerns, but also hold accountability so that those zero harm practices and protocols are honored on the floors. That was a really powerful learning. And we'll get into maybe a little bit later how those provider champions were chosen. That was quite interesting. There were criteria to that. Additionally, and I remember from Riverton, man, they were the ones teaching us about falls with injury. And that's a tough target to really nail down zero harm. And one of the things that they said was so powerful, echoed by Logan and North Pinellas, was our executives are frontline messaging this all the time. They are in the proverbial trench with us in communicating this, getting it out in front of all the providers. It is almost incessant, the messaging that they bring. And they cited how powerful that was for everyone to hear from that executive leadership realm. There was a fourth element that our colleagues, who you are all going to hear from here in just a couple seconds, identified. And that was that as this three-legged stool was coming together, we realized that in order for it to sustainably move forward, you actually have to organize training that maintains that leadership understanding. So that's where this fourth learning came from. And you'll see at the bottom a fifth one. This is for Mark and myself, a kind of a future state that as healthcare systems might come together on these platforms from these learning consortium elements, there could come a day, hopefully a soon day, where that type of exceptional outcome could begin to revolutionize how even healthcare payers look at engaging with healthcare systems to do this right kind of work. Again, the kind of work Leapfrog has championed for so long. So with that, I wanted to ensure that we turn time over to our quality and safety colleagues, because they are the ones who have really been the stars of this work, so that they can share their frontline perspectives of what they see as far as these learnings within their own realm of work. So Megan and Katie and everybody, if we can turn the time over to you.
Yeah, thanks, Sasha. Good afternoon, everyone. My name is Katie Selman. I currently serve as the System Director of Quality and Patient Safety for MiHIA Health. My background is I'm a registered nurse. I have a master's in nursing leadership and certifications in organizational healthcare safety. And I'm really excited to be here today to talk a little bit more around some of those learnings that Sasha is showing you here on the slide. So one of the best practices that our group learned with the work that we did with the identified Leapfrog groups was around nurse-driven protocols. And that was really identified as a key initiative within those healthcare systems who truly are achieving that zero patient harm. Nurse-driven protocols are really a critical component of patient care because they assist with early identification of deterioration in patient conditions, as well as they spearhead initiation of rapid treatment. We also saw that they truly serve as a proactive method for reducing potentially preventable infections for patients. But a crucial component that we learned for successful nurse-driven protocols at those Leapfrog best practice organizations was that they all had a culture that promoted utilization of the protocols. So an example kind of this concept that we saw at our own organization was an event in which a nurse-driven protocol was in place and should have been implemented and enacted, but it was not. So what we found was that the real issue didn't have anything to do with process or functional difficulties in using the protocol. But fundamentally, what we found was that that culture of teamwork and trust was the issue of why the nurse-driven protocol wasn't being initiated. So just, I would say one of the key takeaways that we learned throughout this initiative and consortium and interactions with the Leapfrog best practice organization is the importance not only of nurse-driven protocols, but that a strong safety culture is really the key to successful nurse-driven protocol utilization. And we started to see that those organizations whose cultures truly fostered that teamwork and trust with one another is where they were having the better utilization of the protocols.
And I would just add to that, you know, Katie kind of gave an example of where protocols didn't necessarily work. And I'm going to share kind of a similar story, but is a way of showing that these protocols really can work when they're implemented well. So back in 2019 and 2020, we at MiHIA Health were experiencing less than desirable rates of our C. diff infections. We had SIRS of over, 1.0. So myself as the infection prevention manager worked with our group, and we developed a nurse-driven protocol for nurses to order C. diff testing when patients met certain criteria. It went to the medical staff approved it, and we implemented it, but we didn't have a lot of success with that. Again, as Katie's kind of already alluded to, the problem was that we did not have the support from our providers. Nurses still felt the need that even though the patient met the criteria for the protocol, they still had to go to the provider and get permission to place that order, even though it had already been approved by the medical staff. So in the second quarter of calendar year 2022, we decided to take our protocol, exact same protocol, and placed it into a physician order set for the providers to order. Since we've implemented that, we've had great success. So we know that the protocol works. We've actually seen in the last 6 quarters, our C. diff SIR drop dramatically. We've seen it 3 of the last 6 quarters be below 0.286 or less. And our most recent quarter, quarter 1 of this year, our SIR was 0.087. So that means that over 91% of the patients who were expected to acquire a hospital-acquired C. diff infection, we were able to prevent that through the use of our protocol. So just goes to show, we know the protocol works. What we really were missing is that support from the providers.
Can I ask a question about that?
Absolutely.
As a non-clinician, let me just ask how that, can you maybe parse through a little bit more closely what the difference is between where you were, what happened before with let's say the order set around C. diff and what happened after? I guess excuse my non-clinician.
No, that's fine. So prior to putting it in an order set, it was available in the EMR to be ordered. We actually had the protocol set up that if this patient met certain criteria, the nurse could go in there and place that order on behalf of the provider.
Okay.
But nurses felt that they couldn't just do that on their own, that even though they had this protocol that said, if the patient meets A, B, and C, you can go ahead and place that order for the physician. They still felt the need to have to go ask the provider to say, hey, you know, Sherry met A, B, and C. Is it okay if I place that order? They still had to have permission, they felt, to place the order.
And they felt that way because they were maybe hearing resistance or hearing some
correct.
Or, okay.
Yep, absolutely. Good question.
And so then what
then what we did is essentially we took our protocol and we said, okay, the providers, you know, aren't allowing, or the nurses feel they aren't being allowed to order it on their own. So let's put it back in the hands of the provider. So it is in the hands of the provider. The provider has to order it now, but it's the exact same protocol that we had set up for nursing to be able to do. So we know that the protocol works. The piece we were missing initially is just that sense from the nurses that it was okay to implement this protocol that had already been approved by the medical staff.
I see.
So Katie and Sherry, I think these are great examples. I kind of want to chime in here from our sense. My name is Lynette Schneiderman. I'm the quality manager for Ascension St. Mary's.
And I'm Carissa Kemi. I'm one of our infection preventionists here at St. Mary's.
So we just kind of want to chime in too, because I think as long as, you know, we're talking about nurse-driven and protocols and we're talking here about the physician engagement, this is really where that next piece kind of flows, and that we've been really working hard with is our physician champions. We were having an issue here with our upticks in hospital-acquired infections as well. So really we started with leading and appointing physician champions, one for each of the HAIs. We had various methods of appointments, but we really were looking at them from performance and ability to lead. We'll get more into the next steps too with how we really engage with our physician champions. But really from there, we were able to reduce our overall hospital-acquired infections by over 50%. So that was a real big win. And really the key to that was engaging our providers with our nursing champions as well, as long as with our multidisciplinary teams, keeping them in touch with putting together the action plans, attending the work groups, being able to be the champions to bring the information along to the other providers was really key. With this, we did identify some gaps that we had as a system too, really kind of laying out those clear tactful expectations. Something that we did notice is we use very vague terms when we label champions. We use the words engage, review, But what do those really mean? So engagement, we really need you, like I said, to attend work groups, to carry on this information, provide that one-on-one coaching, perform those non-biased objective reviews, and be able to do that follow-up with your colleagues. Those are really key opportunities that we've been working for our next steps with Physician Champions. But that's really where we've kind of landed at with this piece, which we just found was so crucial to encourage those nurse-driven protocols as well. Do you want to talk a little bit about
Yeah. So when we first started having some champions, we kind of had a first go round where we selected them maybe based off of their performance in a specific HAI group, not necessarily maybe because they were great with being innovative or being great leaders, primarily based off their clinical practice. We quickly learned, though, that to make change, you really do need someone who is a true leader. So we really looked at appointing kind of some new champions and had great success because not only were they clinically proficient, but they were innovative with their approaches. They had good ideas to bring to the table. They were willing to change their own practice as well as turn around and engage with their colleagues to change their practice in a non-confrontational manner. They really showed that they could be non-biased when they did review others' charts or even their own, maybe taking a step back to say, oh, retrospectively, I suppose I should have done this differently. Let's look at how we can fix this in the future. And they really had to have a passion for improvement, not just being told, hey, you have to be the one to drive this, but really buying into the role that they're in and thinking, oh, I'm responsible for this. I'm the point person. I am responsible for the success. And so having that passion where they actually want to see the improvement, such as with CAUTI and CLABSI, really made a big difference on their willingness and kind of those outcomes that we were seeing.
And I think it just really kind of helped reinforce and rally everyone behind knowing that they had a physician champion behind them on these decisions to move forward in success with our improvements.
It's really exciting. We have a couple of, oh, go ahead.
Go ahead.
Megan Burke.
Oh. I'm Megan Burke. I'm the Director of Patient Safety and Quality from Covenant Medical Center. We found that a lot of times people hear all these things, protocols, champions, all that, and think, oh, we have all this in place, so we're fine. And my own organization, we have these things, but it's just not consistent. That clear and consistent is huge. Just an example, we had an order for a Foley catheter for a renal patient who was not making urine. So the nurses tried to push back to say there is no need for this. It doesn't meet indications that we had clearly identified in our organization. And the provider was just like, just do it, just do it. And so we found that although these things are in place, there are still those one-offs that get through, and that doesn't allow us to have that consistent zero harm. A lot of times folks might think they're doing it, but if they really look into it, they might not be. And that's where that training comes through. We train our leaders to be leaders, to do the leader type things, but do they truly understand how to hold folks accountable, to be consistent each and every time?
So we have a couple of questions. I think some of our viewers are very interested in digging into some of the issues that all of you have just brought up. So maybe it's okay with you, Dr. Savage, we'll just dig in a little bit here. And then I think we should also touch on some of the other pillars of excellence that you found. Is that a good plan?
That sounds great.
Okay, so we have a question about really a request for an example of the C. diff protocol and order set, kind of getting at my naive question. I guess I'm not as naive as I thought, really wanting to understand really how that played out. I think there was another question about the C. diff, really wanting to understand through that, how that directly related to the decrease in your C. diff SIR.
I can take that. This is Sherry. I'd be more than happy to share our protocol. It's built into our electronic medical record. It did a couple of things. One of the things it did, it really encouraged the early testing. It also encouraged providers to think about, is there another reason that could explain the patient's diarrhea? Maybe it's not C. diff that the patient has at all. It also sets them up. It actually tracks in the background, looks for specific criteria in the record to say, okay, what's the patient's age? You know, we don't test patients that are less than 1 year of age. Has the patient had a negative or a positive test within the last 7 days or 14 days? Is the patient received any, you know, medications that are pro-motility agents that might be an explainable reason for further diarrhea? And so if the patient doesn't meet the criteria to be tested for C. diff, then they can't place that order. If they strongly feel that, you know, even though the patient's not meeting criteria, they have some reason to believe that that patient may have C. diff, there is basically they consult with the infection prevention nurse and they review the case with the infection prevention nurse, and the infection prevention nurse is able to kind of override that hard stop and place the order for the provider. So it does make the provider stop and think about ordering. Is it appropriate to order for this patient? And it does encourage them to test earlier in the patient's hospital stay. Katie, did you have anything to add to that?
No, I just think it's a really nice example of, you know, having almost to Lynette and Carissa's point, kind of this relationship between provider champion as well as, you know, that strong nursing type subject matter expert maybe around the specifications of measures and things. I just think it's a really good example, because that truly is how kind of the ordering and the success of ordering is done from the MiMichigan protocol that Sherry is referring to.
And how do you think that improves the SIR?
Because if you're testing patients earlier in their stay before hospital day 3, it's a community onset case of C. diff. Versus if you're testing them afterwards, then the hospital owns it when they might have in fact had it when they were admitted to the hospital.
Yeah, so it speaks to that early identification of conditions with patients when they're coming into our hospital versus, you know, there's times when it truly is something that the patient acquired while they were here under our care. So I think it's really that difference of catching those types of things early within a patient's stay and ordering prep testing.
Yeah, and reflects really what is truly hospital acquired.
And if I can add something to that, Leah, as well, what Katie and Sherry have just pointed out, because I work in that organization, right? This was brilliant display of nursing subject matter expertise. It was so awesome because they took what is a nursing domain, the safety, they are the subject matter experts, and they put it into a domain in conjunction, dare I say, with providers who championed hey, let's get this into these order sets. And before you know it, this nursing domain, these nurse-driven protocols were suddenly completely accepted by the providers. It was such a great example of how politically even you can navigate some of these complex challenges. But I'll put an exclamation point on, this was all nurse-driven. And that's, I think, that is probably the greatest learning that we came across from going across the country, learning from these partners.
Well, and I think that's a really important point, that it's small p politics, which doesn't mean it's small politics. It just means that it's not maybe the usual partisan stuff, thank God, but it's the small p politics. It's how the role of nursing, the expertise of nurses is incorporated into care. And it sounds like, I think that's a breakthrough that you observed that in these extremely high performing hospitals. So we have a question about, many of our one-offs involve travelers and locum tenens. How do you address those related challenges? How did you find that the hospitals you looked at did that, or how have you done so? Anyone want to answer that one?
I would say in terms of our traveling nurses, the protocols, you know, it's already built into the electronic medical record. So it's just a matter of orienting them to that. The locums, I don't know, Sasha, if you have any knowledge of how, we do have some information that all new providers get when they come in, that covers a whole host of things, including hospital-acquired infections. So that's a piece of how we address it. So even locums get that information.
Yeah.
It's just a paper handout.
I think it, yeah, I think what it highlights though, and that's a great question, it highlights the crucial importance of an active frontline provider champion, because the turnover, we all know, especially COVID taught it to us more than ever. You're going to have lots of people coming in and, you know, filling gaps in terms of care. Those folks are going to have no capacity to drink from that tsunami and understand your system as quickly as what we'd ideally like them to. But a provider champion who is thoughtful, who is courageous, who is a subject matter expert because the nurses have trained him or her, who's available and aware of the challenges, can head off some of those concerns by going and meeting with those people. You know, I think a lot of the exploration would best be done by said provider champion. And in so doing, they can emphasize the importance of, hey, I know you're new here, but please understand these protocols save lives. And in this organization, we are zero harm. When that comes provider to provider, that is powerful.
Yeah, that is a great question. I'm going to piggyback off that because we did hear from one of our best practice organizations that as soon as we reached out to them, they had an infection. And when they did their tracer, they found that it was from a contracted entity that was doing their hemodialysis. And there was a drop in the protocol. So having that clear and consistent and intentional communication from your leadership to those you are going to partner with, whether it's travelers, locums, or other organizations, that you have that commitment. So not just providers, but having that executive level presence when it comes to those negotiations.
I'm glad you brought that up, Mark, because I wanted to make sure that we get to the other two kind of pillars that you found. We've talked a lot about nurse-driven protocols and provider champions, but you also found executive presence and training, both of those areas to be very important. And you just touched on executive presence. Could you talk a little bit more about what you found as key? What's different in the health systems that you looked at? What was different about executive presence than you saw or that you otherwise would expect?
Yeah, absolutely. Where this one came from is it was our organization that we talked with on CAUTIs. And what they have at their daily safety huddle is their CNO runs that daily safety huddle. Sometimes other mid-level managers or other leaders are running it. But what she communicated to us was that she is there every day. And one thing that they took very serious are how many lines and how many catheters are in place. And then how many can come out that day and what's the plan to get those out. So having that CNO front and center every single morning, asking her leaders, what's your plan to do this, was very, very powerful. As Sasha talked about, we found that with Falls with Trauma, having executives be engaged in specific campaigns and really holding accountable to those red line rules when things do go awry. Not only does a provider have to have that frontline staff's back, but they have to know that that goes all the way to the top, whether it's the CNO or the CEO or the CMO. That is what we found amongst these organizations, and we found it with everyone that we spoke to.
You know, it's interesting
that we had implemented here for that type of example was for our increasing HAIs, we had work groups developed. Really, our CNO, CMO were heavily engaged in part of those work group charters too, to get it going. That way just set the message clear across the organization that this is a priority, this is a focus, and it really helped rally everybody around that too. But they were really part of that initial work group to get the work up and going.
Sounds like those are some good tips for the person who asked us. We have a Foley removal protocol built into our Foley order set and still struggle. Any tips for organizations? Sounds like those are two. Are there any others for this questioner?
We have a daily Foley prevalence that gets reported out at Safety Huddle. So that is something, just an idea of something that's front and center every day. You're looking at it. And if you're setting thresholds or targets, your executive team is very aware of where we're sitting at, what we're working on. And if we're above that, then what's the plan to get these out? Can we reevaluate some of these lines? And that's just a suggestion that we're looking at day to day.
And then to help with that consistent messaging, then that messaging is carried down from our whole hospital huddle down to the frontline nursing staff. So it's the executives down to the directors, the managers, and the frontline staff, and they're all expected to have that same momentum moving on it, kind of across the board. So it's not just, oh, this is what they said, and it's really everybody's on the same page about it.
And that's another area we've really significantly reduced just within about a year. From 1 year to the next, we really reduced the number of Foleys that were getting placed in patients and the duration they were left in, and really educating and utilizing more potential external alternatives, or like I said, just really getting the Foleys out in a more timely manner.
And hardwired nursing protocols.
Correct.
Throughout the organization.
Yes.
What can we touch on one more, which is training? I just want to make sure we got to those 4 pillars of what you found. Does anyone want to talk a little bit about components that were critical to the training? I mean, obviously every hospital has a major training program. What did you find that was different?
Yeah, I'll kickstart that, Leah. Is that every organization teaches one how to, I would say, manage people from a business perspective, time cards, PTO policies, attendance, tardiness, etc. But this is one that we identified as a group, and that having a robust training program that teaches individuals how to become leaders and embody these zero harm principles and make sure that they're carried out can make more effective provider champions and more effective frontline leaders. So it was that commonality of less about how do we train individuals to be a good organizational widget mover per se.
You froze a little bit there, Mark. Can you repeat your last part?
Oh, but what it really embodies to move this type of culture forward.
Yeah, so to piggyback with Mark, this was one that I think we had identified separate from the 3 best practice hospitals while we were working through our local regional group, because as we were talking, we all realized that a lot of providers or nurse champions are they're maybe sometimes picked based off of tenure. They've been with the facility for a long time. They know a lot. Maybe they're a pretty good leader or a manager, but a lot of times when people are chosen for these roles, you're not really told how to identify stakeholders, how to actually move and do tangible work on action plans. You might know what an A3 is or what an action plan is, but how to actually execute and create work out of these. So that was one of the things that we wanted to focus on from our group, is training that actually promotes leadership, that you can actually move and create actual things from, rather than just, oh, I know how to do this, or like, I know that for being a great leader, you need to be good at communication. It went a lot deeper than just those general characteristics that we know that leaders have, but people who actually were driving the work, like Mark said.
And then really at the next part, sustainment plans. How do we sustain this and continue to improve is really important.
And Leah, if I can jump in and add one quick thing, we actually heard from our quality and safety colleagues and nurses that where people were just selected based on, hey, this person's been here a while, or we like them, or they're interested, frequently that would produce deleterious effects, because those folks would show up to a meeting undereducated or unprepared for the complexity of the work, and would then be afforded too much influence, dare I say, into the processing. And so the kind of training that this whole group identified was really the training that says, here's how you become a subject matter expert. Here's how you champion the effort. Here's how you interface effectively with your nursing colleagues. By the way, here's how you hold crucial conversations with your providers that sometimes are going to push back really hard on you. They're going to say, no, I want this way. You have to be able to do that in a way that ideally brings those providers along and doesn't alienate them, but also holds them accountable so that they interface properly with these nurse-driven protocols. So that was kind of the crux of where that training became so crucial. There has to be an organized approach and then deliberate training on the skill sets that organizations want those leaders to bring forward.
That gets back to that small p politics, really. It's about, are you able to set your eyes on a prize, which is improving patient care, getting to 0, let's say, and then work all of the angles, so to speak, that you need to, which includes bringing people together in new ways and having those uncomfortable sometimes conversations, but really, and building your alliances and doing all of those things that we do in the political world to try to achieve that end. And that's the leadership training that we could all use, I'm sure. That's a breakthrough understanding for me of what really leads to excellence. We have a couple more questions that I want to make sure we get to. Has anyone engaged provider champions to reduce patient falls? If so, can you discuss how the champions positively affected the fall rates? I know you looked at fall rates was one issue that you really did look closely at.
I can chime in from our hospital. We haven't necessarily implemented a physician champion for falls, but we did speak with the providers because we did find with literature that it is more receptive if physicians come in and talk with patients in the family when they're rounding to talk about the importance of, just importance of their fall education, the risk plan for prevention, and also just in stressing the importance of, hey, there might be a nurse in here to help you when you're toileting or things like that. That might be uncomfortable, but if it's hearing from the physician, sometimes it helps reinforce those messages and reinforce those behaviors. So not necessarily a clear defined champion that we have yet to define for that, but we are engaging physicians just to help encourage that messaging to patients and their families.
We do have a program that My Michigan Health utilizes, and it's been quite successful. We call it our Adopt a Unit program, to where we have, and it is specific for falls with injury on targeted units who have more issues with patients having falls, to where an executive is identified. And then, to Sasha's point, it's pretty clear in terms of what that executive's responsibilities are with that unit. And some of those things are weekly rounding up on the floor with those frontline staffs and managers to go over things like audits for compliance of falls interventions, as well as doing any sort of root cause analysis on specific falls. And actually one of the units to where this past year, they've gone, I think 150 days at this point without a fall, and they were one of our worst performers with falls. So that was one of the big changes we've seen with that program. And we think that was probably one of the keys for that unit.
So is it picking the right physician champion, or is it putting the champion in the right spot so that he or she can do the right things? Like, which is it, or both?
I think it's a combination, but my personal opinion is I really think it is having the right executive at the table, because they truly are the ones who are holding this accountability for why they are there and what they're doing. That's just my personal opinion, though.
And I think, Leah, it was brilliant for them to, you notice Katie used very clearly the word executive champion in this regard. Sometimes the champion may best be an executive who may or may not have an RN or an MD-DO degree. It may be somebody in those executive realms who just is the right person to do what it is that you needed done, but they then become trained in the lingo, the metrics, the processing, and everything. And those folks who can step onto those floors and earn the currency of trust, right, which is so crucial. When you can earn trust from the front line, you can move mountains. Mm-hmm. And that's why I think Katie is spot on when she said it's probably more so than the other picking the right person and then training them.
Okay, we have a question. Could you share the training source or content? Just a note, we will be sharing this webinar. We will put it on our website, and we'll send it out to all the folks who are on today. And I believe there's some other additional resources we can make available, and you can ask additional questions through our website once we make that available. So we have just 5 minutes. So one of our audience members asked a really great question that I think would be a nice way to end today's session. Can any speaker recommend one thing we can take from today's presentation and execute at our hospital that will likely result in a positive effect or change in harm? One thing. Who wants to start?
I'll start. No, I will say it's culture. I mean, the old saying, culture eats strategy for lunch every single day. If you can change the culture, everything on here will fall in line.
And how do you change culture? Not letting you off the hook, Mark.
I can take that one.
When you're changing it, I'll chime in. When you're changing it, it's got to come from the top. It has to be a leader
Okay.
who embraces it and changes it.
All right, Megan, you're up. Nope, you're on mute.
It has to come from the top, but everybody in the organization has to buy into that culture and that culture of zero harm. Mark referenced it, the organization that had the infection right before we contacted them. They were devastated by that. It was like a loss, that their perfect score, because that patient was harmed by that. And so everybody owned that in the organization. So if that buy-in can be across the board, it does have to be messaged from the top, but that buy-in has to be across the board. And that does prevent things like those one-offs and people kind of going around those protocols, because everybody is on the same page.
Thank you,
And
Sherry.
Leah, you probably remember when you were part of our summit that we held in February. One of the challenges Mark and I put out to everybody was, it's one thing to bring the message of zero harm. It's another to bring it in a manner that is, to coin Simon Sinek, a limbic message. The start with why. Why are we doing this? It has to travel deep into people's souls. And learning how to message that in a manner, how to message that culture and why it is so crucial is a steep learning curve. But I agree with Mark and Megan and everything that's been said. Culture is where you start, and learning how to message it in a way that grabs people, that serves as a hook, is really important.
You know, that's so important because I hear really great conversations among hospital leaders about, you know, high reliability and some amazing, really amazing work that's being done in hospitals across the country in really changing how they deliver care in such a way that it's really improving their safety profiles. But sometimes what we do need to do is get to the heart of what is successful about those programs. It's not always just the exact steps that were taken. It's the heart and soul of them. It's the why. It's the why we wake up every day and want to do this work and care so deeply about.
Yeah, it's the story, right?
Mhm.
We're humans are storytellers.
Yeah.
And stories sink into our souls. And when the story can be delivered in a way that is gripping, which, by the way, it can be. Zero harm doesn't need to be medical boring, right? Zero harm is kind of one of the coolest stories that's out there.
Mhm.
But it's got to be delivered in a way that that brings the story to life.
All right. So one change, Katie. What should we take away from today?
You know, certainly I would say, like everyone else, it's really the culture. And I think one thing that I just heard and learned loud and clear from one of the organizations, I think Megan just mentioned it, they just had one of those events prior to having the call with us. And everyone on that call, they took it so personal. They take it as, you know, we had a patient come into our organization. It was someone's sister, someone's mother, and they take responsibility for the harm. So I think not only, you know, having the culture and the stories, because they're powerful for clinical care providers, because sometimes we just get caught up in the everyday tasks that we're trying to do our job. But just really having that in the back of our minds is we are caring for our communities, our family members, and our friends. And we just have to keep at the top of our minds, we do not want our community and our families to be harmed when they're under our care.
It's personal. All right, we have we have maybe 10 seconds. I'm sorry, Sherry. So you have your one. You have, okay. Okay, well, I want to thank all of you for this amazingly inspirational webinar today. I wish we had more time because I feel like we have a lot more questions. But again, this will be posted on our website along with the recording of this webinar. You're all going to get as a follow-up a link to that, and also we will have whatever materials we can we've received from all of you. We'll make that available as we get it. And but mostly we just are inspired by what you've said, and I think that you've gotten to the heart of one of the most important aspects of patient safety, which is the dignity of every patient and the personal sense of purpose that every clinician brings every day to their work, which I, as a current or potential patient, am endlessly grateful for. And I appreciate so much that you have taken us to a new level for all of us in improving the healthcare of the American public, just by your example and by your presentation today. So thank you all for joining us.
Thank you, Leah.